Welcome to the show, the 4D show, that is Detailed Discussion Dialogues of Indian Diabetes. Today, we are very happy to have the 48th episode of 4D show. This shows the amount of love you have given to the show, amount of knowledge we have been able to share with you, amount of learning we have been able to do together. We are so proud and so happy to be doing this, and soon we will be doing our 50th episode also. So thank you so much to all our eminent doctors, all the viewers, all the esteemed faculty who have contributed to making this a success. Diabetes, yes, this is what the show is all about. 4D, that is Detailed Discussion Dialogues of Indian Diabetics. We know that Indian diabetics are unique in the sense that not only is the diabetes very common, but the complications of diabetes are common and they happen earlier compared to Caucasian counterparts. The burden of diabetes is huge in our country. As per official figures, it ranges to many millions, and this figure, some people put it at 70 million, some people put it at 72 million. That figure is huge, and the most important thing for all of us to remember is that there are millions of diabetics in our country. There are millions of diabetics of Indian origin who are not living in our country, but these are people of Indian origin. So these are all very, very important questions. And to have a discussion today on the burden of diabetes aspects, what are the challenges we face? What are the solutions we can have? We have a very learned speaker with us. Her name is Dr. Neha Agarwal. Dr. Neha Agarwal is a DM endocrinology from prestigious institutes in our country, and she's working as a consultant endocrinologist at Health World Hospital, Durgapur, West Bengal. So welcome Dr. Neha Agarwal for the show. It's our pleasure to have you here with us.
Hello everyone. I'm Dr. Neha Agarwal, consultant endocrinologist from Durgapur, West Bengal. So we all know that the burden of diabetes is increasing globally, and we have been labeled as a diabetes capital in the world. We have got the second highest number of diabetic individuals after China. If we look at the statistics, in a country of 1.4 billion people, 90 million people are suffering with diabetes, which means that 1 in 11 adult is living with diabetes, and most importantly, 1 in 2 adult is being undiagnosed with diabetes. That means that the number of undetected diabetes is even more than the people who are living with diabetes. And if you look at the number of pre-diabetic individuals, approximately 40 million people in India have got impaired glucose tolerance, which places them at higher risk of developing type 2 diabetes. And why is this rise in the number of people? This is because of the multiple reasons. It has socioeconomic status, demographic, environmental factors, and genetic factors. Basically, type 2 diabetes is a multifactorial disease. It is not only a genetic disease, it is basically an epigenetic disease, which means that we have got certain genes which, if have been exposed to certain environmental factors, then their behavioral gets changed, and then we become more prone for type 2 diabetes. Prevalence of diabetes in India, which was studied in a epidemiological survey by ICMR. It is a 10-year long survey which shows that the overall prevalence of diabetes in India in all 15 states was 7.3%. The prevalence of diabetes is varying from 4.3% in the state of Bihar to 10% in Punjab. It also shows that there is higher number of diabetic patients in the mainland states like Maharashtra, South Indian states compared to the northeastern state. And overall, the percentage of newly detected diabetes was found to be 47.3, which is again a very high number. States with high per capita income like Chandigarh had got maximum number of diabetic patients of around 13%, and it also showed that the states who have got high per capita income, or the urban people, have got more number of diabetic patients compared to the rural areas. Next part is the challenges which we face in managing diabetes in India. There are multiples. First is reduction in the physical activities, increased availability of fast food items, cheap food items, aging population, increased number of people having overweight and obesity, and a few perceptions regarding diabetes. So once we overcome these challenges, we can manage the diabetes very well, and all these issues leads to so significant contribution in the delayed presentation in the misdiagnosis, which further increases the existing burden of diabetes. Now, this is a very interesting study which was published in the Lancet Diabetes and Endocrinology in the year 2017, which states that the prevalence of diabetes is almost double in the urban area compared to the rural area. This study also highlighted that the urban areas has got higher prevalence of diabetes among the low socioeconomic status, and this was attributed to the increased availability of fast food and relatively cheap food in the recent years, which means that the poor diets were easily found across all income brackets. So, this study concluded that easy availability of the processed food was one of the major driving factor for development of diabetes in people who are living in the urban population among the low socioeconomic status. Now, let us look at the distribution of the direct cost in the diabetes care. 35% of the total cost goes to the hospitalization, and this is because if we do not manage diabetes properly, then these people are prone for developing the micro as well as macrovascular risk complication in the future, and for which they will need hospitalization. So majority of the cost goes for the hospitalization. Now, 12% of the total cost goes to the doctor's visits. 22% of the total cost goes to the monitoring and the lab tests which we prescribe, like fasting sugar, postprandial glucose, A1C, and the other tests for high cholesterol, for renal, for kidney profile, for LFT, for various kinds of tests. 22% of the total cost goes to the lab. 17% of the total cost goes to the buying anti-diabetic drugs, and while the other drugs, including antihypertensive, including medicines for managing high cholesterol, the cost is around 11%, and the 3% cost is contributed by the disposable. So overall, we can see that if we can manage diabetes at an early stage, and if we can overcome the challenges which we face in the management, then we can definitely reduce this hospitalization cost, which is a major cost among the management. Now, what are the possible solutions for overcoming these challenges? First and foremost is the awareness, education. If we do mass education regarding the risk factors which leads to onset of diabetes, we can definitely reduce the burden of diabetes. We should train our patients to manage their disease more effectively. Third, we can develop a more structured way of care delivery. And lastly, we should manage the cardiovascular risk factors which leads to development of micro as well as macrovascular complication. And it is again very essential to diagnose and to start early and intensive management of hyperglycemia, so that we can reduce the onset of complications. And it is also mandatory to individualize the glycemic targets. That means that one size doesn't fit for all. We should individualize the A1C target depending upon the other comorbid conditions. The first step towards the solution is to identify the barriers. One, because it is necessary to improve the quality of diabetes care, including the improvement of metabolic control and diabetes self-management. So what are these barriers? These barriers could be at multiple levels. First is at the level of patient. Patient-related barriers include lack of awareness, huge economic stress, denial of their disease, denial that they are suffering from diabetes, denial of that they are at risk of developing certain macro as well as macrovascular complications, stressful behavior, their changing behavior, which means that they do not comply to their medicines, they do not comply to their lifestyle modifications which we advise, and second could be at the rural barriers, which means that there could be different levels of literacy, different levels of poverty. They could belong to different socioeconomic status. Multilingual population, which means that a doctor who is been taught in the West Bengal will not be able to deliver proper care in other state, or the patients who belongs to the other states, they could not be able to communicate properly with the doctors who some other different state. So this multilingual barriers can exist. There could be different kinds of cultural as well as religious beliefs, superstitions, adopting some alternative form of therapy. So these are the barriers which will further increase the burden of diabetes and which will further challenge the management of diabetes. And lastly, and the important barriers could be from our side, that is the barriers at the medical professional levels, which means that our nursing staff, our paramedics are not trained properly regarding the management of diabetes. They are more trained in managing the acute illness, and they find it more rewarding and better paying. So again, it is very important to teach our juniors, to teach our paramedics regarding the management of diabetes, and to involve them actively in the management of diabetes. At the level of hospital, we can even form a diabetes care team, so that we can counsel the patients, we can monitor our patients more frequently by with the help of our diabetes care team. Now again, pre-diabetes again is a very important stage. We should identify pre-diabetes as a warning stage, so that we can, if we intervene at the level of pre-diabetes, we can prevent the development of future complications, and in fact we can even reverse the diabetes, and we can achieve normoglycemia. In a esteemed this organization, that is American Association of Cardiology, it was published that the importance of diagnosing and treating the pre-diabetes population is very important in preventing the for development of future macrovascular complications. And how do we manage pre-diabetes? Mainly by the lifestyle management, which includes physical activity of more than 150 minutes per week, and reducing the overall calorie intake to around 1200 to 1800 calorie per day. And if depending upon the several BMI, depending on the BMI cutoffs, if we find that the patient is having BMI of more than 25, and despite doing lifestyle management is unable to control the diabetes, we can even add we can take use of certain pharmacotherapies like anti-obesity agents, which are orlistat and GLP-1 receptor analogs. This locazepine has been banned recently because of the certain adverse events, and this phentermine topiramate combination is not available in our country. So with the help of anti-obesity pharmacotherapy, we can help our patient in achieving weight loss, and in fact we can even achieve the normoglycemia. So healthcare providers can also consider other pharmacological agents like metformin, pioglitazone, and GLP-1 receptor agonist for managing pre-diabetes if cost is a issue for the patients who cannot afford GLP-1 receptor agonist. And even we can use SGLT2 inhibitors in the pre-diabetic stage to achieve normoglycemia as well as to promote weight loss. So if medical management fails to achieve the glycemic control, we can go for the bariatric surgery with the goal of reversing pre-diabetes and helping obese patients to lose weight. Now, the third treatment strategy for the patients who have got diabetic, who has got their blood sugar at the range of A1C of more than 6.5%, or who have got the blood sugar value at the of the diabetic cutoff. For them, we have got several novel therapeutics, which include DPP-4 inhibitors, SGLT2 inhibitors, and oral as well as injectable GLP-1 receptor agonists. It is very important to start the management of diabetes very early and intensively. Our approach should be aggressive. Our approach should be to achieve the glycemic goals at an earlier stage, so that we can prevent the further deterioration of beta cell function, and possibly we should so that we can preserve the beta cell reserve also. Along with the diet and lifestyle modification, along with the metformin therapy, novel therapeutic agents should be used to achieve early and aggressive glucose control. Now, moving on to the this FDC combination of SGLT2 and DPP-4. This FDC will help us in achieving glycemic control at an early stage. This FDC has got a synergistic effect. We know that SGLT2 inhibitor has got insulin independent mechanism of reducing glucose. It promotes glucosuria and hence reduces glucotoxicity. It has got also certain indirect pancreatic effects, which means that it improves the beta cell sensitivity. However, it increases the glucagon secretion, because of which there is a slight chance of hyperglycemia, and this effect can be countered if we use DPP-4 inhibitor along SGLT2 inhibitor, or this can also be countered by adding in metformin therapy. Now, in several studies, it's been seen that we Indians have got our incretin secretion something different. We have got high carbohydrate consumption, and because hence we need incretin based therapy. So this DPP4 inhibitor, it inhibits the enzyme DPP4, and hence it increases the GLP and GIP hormones, which are incretin hormones, which further increases the insulin secretion and reduces the glucagon secretion, thus countering the effects of hyperglucogonemia caused by SGLT2 inhibitor. So this combination is synergistic. It reduces hyperglycemia, and it also provides other pleiotropic effects, like it promotes weight reduction, it also reduces blood pressure, even it improves the lipid profile also. There are several benefits of using this FGC, and these are: it is a safe and rapid anti-diabetic agent. It provides sustained glycemic control. It improves both insulin resistance as well as promote beta cell preservation. It reduces body weight, it reduces blood pressure, which are the extra glycemic benefits, and most importantly, it reduces the pill burden, which improves the patient's adherence and compliance to the therapy. And overall, this combination is cost effective, and importantly, this combination comes with a lesser risk of hypoglycemia. I would say it doesn't cause any hypoglycemia if it is used judiciously, but yes, this can lead to hypoglycemia if it is used with agents which leads to insulin secretion, like sulfonylureas. Now, last but not the least, the other strategies which are again very important, despite therapeutic approach, despite adding medical therapeutics, we should not forget the importance of lifestyle management. It is very important to counsel our patients to adopt to a healthy lifestyle, which means that they should control, or they should follow a portion control diet, which means that they should adopt food items which have got low glycemic index, like whole wheat, brown rice, oats, and they should avoid the food which has got high glycemic index or which has got low fiber, which includes white bread, noodles, and white rice. So dietary intervention is a vital element in managing diabetes, and the importance of exercise we should not forget, and we should emphasize all our patients to be physically active. We should counsel them to do at least 30 minutes of brisk walking for 5 days in a week. And all these parameters, if are done together, or if are advised together, then it will help in managing diabetes properly. And again, very important that we should counsel our patients to check their HbA1c at least twice in a year. If for patients whose A1c is very high, for them we can even go twice, or we can even ask them to do it every 2 or 3 every third monthly.
Malnutrition, and we know that malnutrition still seems very prevalent. And then we talk about diabetes, which has always been considered a disease of of well-off, wealthy, shall I say. But but still, we find lots and lots of diabetes in this country. So despite so much of malnutrition, why is India called as the diabetes capital of the world?
Thank you, sir, for asking this very interesting question. Yes, actually, whatever starts, it's in utero. There is an hypothesis of thrifty genotype and thrifty phenotype, as well as there is we Indians, especially South Asian population, has got a typical phenotype which is called as thin fat phenotype, which means that we have got high visceral fat, but there is the overall adipose tissue is more in South Asian population. So with the concept of this thrifty genotype phenotype, which means that we have got genes, thrifty genes. Our genes are more prone for the are trained for the situation, for famine situation. So, and India was believed to be a very poor country many years back. So at that time, our genes got adapted to a situation where we were not given proper, we were having a less amount of food. But once this if a malnourished mother delivers a child with a small gestational age, or deliver a child of IUGR, and if this child is being given food later, or takes excess amount of food after birth, then it has got a tendency to gain weight. And adhering to this concept of thrifty genotype, these genes once have been exposed to excess amount of food, then it leads to obesity, and hence there is a higher risk of developing young onset type 2 diabetes, and that is what we are seeing now. For example, our mothers who were who have not the mothers who were malnourished around 40 years back, now their children are around 40 year of age, and hence we are seeing the higher population of diabetes in our country.
Yeah, it's a very important point you mentioned. And now we go to the next important aspect, which is prevention of diabetes. Always, we have heard of this term called as prevention is better than cure. And there are various levels of prevention: primary prevention, secondary prevention, tertiary prevention. When it comes to diabetes prevention, where are we actually? Especially when it comes to primary prevention, what do you think is the status of primary prevention of diabetes in our country? Can we really prevent diabetes? If somebody has got pre-diabetes, can we really is that patient bound to go into a proper type 2 diabetes, or can we halt its progression, or maybe prevent the diabetes progression for a time being, or forever, or whatever it is? And if the patient already has diabetes, how can we more act at that level in terms of secondary prevention? Can we help patient do a bit of a reversal of diabetes, do the management in such a manner that over a long period of time the beta cell preservation is made, the some amount of beta cells are able to act in a better manner for the lifetime of the patient for a longer period of time?
Yes, as I already said, pre-diabetes state should be taken as a warning situation, which means that it is the time or it is an opportunity at the physician end that we should counsel our patient for active lifestyle, which means that they should take proper healthy amount of food, they should follow a restricted diet, and they should be physically active. And if they are found to be obese, and if they have a BMI of more than 25 as per the Asian BMI cutoff, then they should be added certain kinds of pharmacotherapy to reduce weight. So if we treat pre-diabetes properly, then definitely we can achieve normoglycemia, and definitely we can reverse diabetes, because at pre-diabetic stage, at least there is 50% of beta cell preservation still exists, and if we preserve this beta cell, then we can prevent our patients from moving to the diabetes stage in the future.
That's the most important aspect. So more and more awareness we spread about diabetes, the more and more knowledgeable our patients are there about diabetes, they will be able to take care of themselves in a better manner. They will be able to diagnose and prevent those illnesses in a better manner. So what is the degree of knowledge and awareness in our population? And especially when I talk about a rural population, what is the degree of knowledge and awareness in our population?
Yes, sir. Actually, it is very poor. If we see regarding the awareness of diabetes in the rural population, it is actually very poor, because that could be there could be multiple factors. There could be lack of facilities available in the rural areas. There could be lack of proper literacy. So definitely we should to improve this awareness, we should conduct some healthcare camps at the patient level. We should teach them that about diabetes, about its management, and we should also do routine health checkups or routine screening among these patients, so that we can train them, or we can educate them regarding diabetes. And if once this mass campaign is taken properly, then we can definitely beat diabetes, and we can even prevent the development of future complications.
One important aspect which is very, very important for us to emphasize is that many patients are still aware, but still not taking care of their health, of the taking certain actions which can help prevent the diabetes. So there definitely comes the role of medication, right? And do medications are like a replacement of diet? Can diet be a replacement of medications, or can they supplement each other? Do medications supplement each other? Or especially when you consider an Indian diet where you have a very high carbohydrate rich diet, what is the situation there in terms of in terms of the medications, whether they are able to cover some aspects, supplement that aspects, and what is your take on all that?
Sir, I do believe that we should both the therapies like lifestyle management as well as the medical management or the addition of medicines, they supplement each other. Neither of it can we can't manage diabetes with like only with the lifestyle, or only with the medical management. So we should do it. They both have synergistic effect. Yes, definitely in the pre-diabetes stage, initially we should start with the lifestyle, and if we find that we are unable to control glucose values, then we should take help of the medicines or the therapeutics. And in case of diabetes, in a frank type 2 diabetic patients who are having several kinds of other cardiovascular risk factors like hypertension, high cholesterol, obesity, in those patients, along with the lifestyle management, we should straightway start with the medical management, as we have seen from the various landmark trial that if the period of hyperglycemia is long, then if we expose our patients to the prolonged period of hyperglycemia, then it leads to development of microvascular complication and to some extent macrovascular complications also. So in my point of view, we should do early and aggressive management, and we should take use of help of this medical management along with the lifestyle management.
So thank you so much for your views. And one important thing which we always need to emphasize is that many patients take the pills. There are so many pills. The compliance becomes an issue and the expenses become the issue. So how in your practice you help the patients take care of their diabetes in a better manner and encourage them to have compliance with medications, compliance with the pills which is necessary for them, and also compliance with the dietary therapy. So any practical tips on the same?
So very true. You have said very true that yes, our patients have got various kinds of comorbidities like heart disease, stroke, high cholesterol, hypertension, and because of which they are on multiple pills, and because of which their overall cost, healthcare cost increases as well as their pill count increases. And most of my patients, they say is that, madam, when should we eat? Like, we are taking pills most of the time and we are not getting any time to eat food. So how to manage all those things? So for them, I say that it is better to use combination pills like a FDC. As this FDC, if used judiciously, it leads to decrease in the pill burden, and also it improves the treatment compliance as well as adherence to the therapy. Our patients, they do not tend to forget the pills. If there are multiple pills, then definitely there is high chances that they will forget either this pill or that pill, and in that way the management the management will not be successful. So if we take help of FDC, either in diabetes management or either in hypertensive management or in some other disease management also, then definitely we can reduce the pill burden, and we can increase the treatment adherence and compliance, and we will have better control of all the diseases.
So these principles which are beautifully highlighted by you, if a patient follows and if a doctor shares with the patient, it will surely help manage their diabetes in a better manner. So any concluding remarks, any recommendations from your side in terms of how we can help our patients manage our diabetes in a better manner and also ease the burden of diabetes in our society?
So, first of all, I would like to emphasize on the fact that we should not deny that we Indians are at higher risk of developing diabetes compared to our Caucasian counterparts, and we are even at higher risk of developing complications because of the risk factors which we have discussed. So we should go for mass screening. We should screen after the age of around 35. After the age of 35 years, we should screen for diabetes every yearly. And if and especially for those individuals who have got higher risk of developing diabetes, like who has got family history of diabetes, who are obese, for women who have got history of PCOD, or for women who have got history of gestational diabetes, at least we should screen them properly so that we can detect them early. And early detection, early management, aggressive management is the key in managing the diabetes and its complications. And as well as mass educating about how to manage their diabetes, how to follow a healthy lifestyle, how to do a proper checkups with their physicians, and most importantly, we should not forget that one size doesn't fit for all. We should individualize the therapy depending upon the risk factors. A A1C target of 6.5 would be good for a patient who is young, who is obese, diabetic, but not for a patient who is having certain risk factors like CKD, liver disease, or an elderly patient. And last but not the least, we should train our patients about the risk of hypoglycemia. Thank you everyone.
So thank you so much, Dr. Neha. It has been wonderful having you here with us. Thank you for sparing your time, and to all our viewers, a very, very